Good morning, everyone. Bonjour à tous. We're delighted to welcome you to the Deep Space Healthcare Challenge webinar. Bienvenue au webinaire du défi des soins de santé dans l'espace lointain. My name is Annie Martin. I'm the portfolio manager of the Health Beyond initiative at the Canadian Space Agency, and I will be your co-host for today. This webinar will be in English, but please ask your questions in the language of your choice, either French or English. Ce webinaire sera en anglais et nous vous invitons tout de même à poser vos questions dans la langue de votre choix, que ce soit l'anglais ou le français. Je vous rappelle que les documents officiels du défi sont dans les deux langues et beaucoup d'informations s'y retrouvent. Mais si vous souhaitez une traduction de certains passages, s'il vous plaît, nous l'indiquer dans le chat et nous ferons en sorte d'y répondre le mieux possible. Alors voilà, Brad.
Merci, Annie. Hi, everyone. My name is Brad Andrews. I'm an Impact Canada Fellow with the Health Beyond team and the lead for the Deep Space Healthcare Challenge. And yeah, it's my pleasure to be your co-host along with Annie for this event. And thanks for coming. So this webinar will expose some of the challenges of healthcare delivery in deep space and in medically isolated communities here on Earth. The session will highlight the opportunities that exist for Canada to make a meaningful contribution to deep space healthcare while catalyzing transformational changes in the way medical services are provided, with the ultimate goal of bringing the care to where it's needed, both in space and on Earth. So just a few quick housekeeping items before we dig in. As you can see, we'll have two keynote presentations today, each of which will be followed by a 15-minute Q&A. We'll also be providing a bit of an outline on the challenge itself, which will also have a Q&A section dedicated to that. The webinar will be recorded, and we will be able to share that with registered participants after the event. Attendees, just please make sure you are remaining on mute. If you do have any questions for the presenters, please post them in the Zoom Q&A you'll see at the bottom of your screen. And we'll answer them during that Q&A component of the presentation. You're welcome to ask your questions, as Annie said, in the language of your choice, as long as that's English or French. And we encourage presenters to review the chat thread following the presentation so that they can answer any questions they weren't able to get to during that Q&A time. You'll also hopefully have noticed that there's a dedicated Slack channel for networking. And this will be active throughout the duration of the workshop and afterwards as well. So please make sure to use that to track and network with each other. We'd encourage you to do that. The link to join this channel should be shared in the chat now as well. If you do experience any technical issues during the event, absolutely let us know. We'll do our best to address them. And with that, I will turn it over to Annie and we can begin.
Thank you very much, Brad. So a little bit of background on deep space healthcare. So as the international community begins to plan for crewed exploration class missions back to the moon and onto Mars, the mission scenarios present new challenges. The physical distances and communication delays over these vast distances require new approaches to the provision of medical care, and it's why new innovations are required to ensure crew's health, security, and well-being. Right now on the International Space Station, the astronauts rely on terrestrial support for most of their medical needs. They can consult a doctor using telemedicine procedures in real time. And if a medical emergency would occur, there is possibility of an emergency return. There is currently a limited number of technologies on board because even though spaceflight is a risky business, effort on prevention, crew selection, and qualification for flight, combined with a thorough risk assessment and mission profiles, the requirement call for minimum medical devices. All that to say, the crew rely on the people on the ground for their healthcare. Missions to the moon and Mars mean longer trips and more risk for astronauts as compared to the International Space Station missions. And this includes more time in weightlessness, more exposure to radiation, longer periods of isolation and confinement, increased delays in communication with Earth, decreased ability to rely on Earth for food, materials, and medical assistance, limited or no possibility for emergency evacuation and resupply, and medical conditions will need to be managed on the spot by the crew on their own. So in essence, as we travel further from the Earth, we must transition to advanced telemedicine capabilities for moon missions, and then on to providing the crew with almost complete medical autonomy for missions to Mars. Technologies for health monitoring, diagnostics, prevention, prediction, treatment, countermeasures, just-in-time training will be required to empower the crew and augment their capabilities to manage their health by making them self-reliant. Even though CSA mandate is to provide healthcare to astronauts, we are approaching the development of solutions by addressing shared challenges in healthcare. So challenges that are similar in space, in remote and medically isolated communities, and other operational settings with a remote and isolated component. The CSA is dedicated to enabling socioeconomic benefits from the investment we are doing for space. And amongst those synergy, I will highlight some. So there's the lack of access to standardized healthcare, expertise, and resources of medically isolated population, like northern, rural, indigenous communities, aging population, and people with reduced mobility, the military, industrial platforms, and so on. Another similarity is the lack of connectedness of certain regions in Canada. The instability of the network, the lack of internet capacity, or communications blackout due to infrastructure or environmental conditions lead to similar healthcare challenges, whether on Earth or in space. We can also think of the difficult and costly emergency evacuation. For example, evacuation from a northern community to urban settings can be costly and provide additional stress on the patient and his or her family, which could be avoided with proper tools provided on site. Finally, as we think of the growing cost of health, coupled with the aging population and decrease of working population, technologies and concepts applied for space may be relevant for terrestrial settings, whether in northern or urban settings. To tackle this challenge of remote healthcare, the Health Beyond initiative was created at the Canadian Space Agency to leverage the ambitious vision for human space exploration and the healthcare needs of astronauts to contribute to remote healthcare delivery in Canada. The Health Beyond initiative is led by a transdisciplinary team of experts from throughout the Canadian Space Agency, working in close collaboration with external leaders and champions of remote healthcare to identify and develop innovative, relevant, and sustainable health solutions for deep space missions. As we are defining and developing options for Canada's contribution to deep space astronaut healthcare, the Health Beyond initiative consists of three main components. So first, partnership. We're committed to the development of collaborative approaches with stakeholders. This includes collaboration with international agencies as well as Canadian organizations to facilitate the co-development of solutions for both terrestrial and space applications. Second, starting in 2023, we'll establish a demonstration site in a remote location in close collaboration with local partners. And the initiative will assess the utility of Canadian and international healthcare innovations to address the common healthcare challenges mentioned before. Finally, we have collaborative research and development activities through investment in the development and advancement of Canadian health technology capabilities. And this challenge is one mechanism we use, and we're looking forward to what you innovators have to propose for this challenge.
Great. Thanks, Annie, for a great introduction to the Health Beyond initiative and the work that CSA is involved in. So I'd like to take a minute before we get into our keynotes to provide just a quick overview of the Deep Space Healthcare Challenge itself to give you some context. So first of all, what exactly is a challenge prize? Some of you will be familiar with this, some may not. So challenge prizes are essentially open innovation tools that are designed to bring new ideas and new innovators into helping solve challenging societal problems. They're set up to provide incentives that reward the innovator who can first or best solve a given problem. And this is where they differ a bit from traditional grant and contribution programs in that they're paying for outcomes and not for future research or development. So as such, the prize amounts are fixed. They're not tied to expenses as we may see again in traditional grants and contributions. So the Deep Space Healthcare Challenge itself is looking for solutions that support both deep space missions and remote terrestrial communities. And specifically, we're asking innovators to develop diagnostic and detection solutions that can support frontline health workers in identifying medical conditions within remote communities now and eventually on long duration space missions. So I just want to stress that the goals of this challenge are really to see the development of technologies that are purpose-built for isolated communities and that could eventually be used in space. So the solutions should be supporting the autonomy of remote communities and their practitioners. And at the same time, these will be providing a pipeline of technologies that could be adapted through the CSA for use in space in the future. So because we want these technologies to respond directly to the unique challenges of providing healthcare in remote communities and in space, we've invited two pretty amazing speakers to provide some deeper insight into the context of where these technologies are pictured being used. So I'll pass it over now to Annie to introduce our first speaker.
Hi, Brad. Sorry, I was trying to click start video, unmute. Awesome. So thank you for this overview of the challenge. And it's my pleasure to introduce you the first keynote speaker today. So Dr. David Saint-Jacques. So David Saint-Jacques is an engineer, astrophysicist, and a family doctor by training. He is happily married and proud father of 3 children. He has always been keen on exploring the world around him. Prior to joining the Canadian Space Program in May 2009, he practiced family medicine in a northern Canadian village overlooking Hudson Bay. Before that, he worked as an astrophysicist in Cambridge, United Kingdom, Tokyo, Japan, Hawaii, USA, and Montreal, Canada. He was also a clinical faculty lecturer for McGill University's Faculty of Medicine and an engineer for a Quebec-based small business. As a member of the International Astronaut Team, David Saint-Jacques has acted as Capcom, the liaison between the team on the ground and the crew in space, and carried out various operations, planning, and support functions at NASA's Mission Control Center and Astronaut Office. On December 3rd, 2018, he flew to the International Space Station as an Expedition 5859 flight engineer and co-pilot of the Soyuz spacecraft. During his 204-day mission, he conducted a series of scientific experiments, robotic tasks, and technology demonstrations. David Saint-Jacques became the 4th Canadian Space Agency astronaut to perform a spacewalk and the first to use Canadarm2 to catch a visiting spacecraft. David, could you please share what it was like to live and work in space, what the future of space exploration holds, and what healthcare challenges can be foreseen?
Merci, Annie. Merci, Brad. Hello, everybody. Can you hear me? Can you see me?
Yes, we can see and hear you.
Okay. Yes, so my internet connection, we never know. Let me know if it goes flaky on you, and I'll look for alternatives. As we say in the world of space exploration, there's no problems, there's only solutions. I have a few slides I'd like to share with you. So let's see if I can swindle that. Share that. Do you see my slides?
Yeah, we can see them, David.
Very good. Okay. So yeah, I came back from space a few years ago already. And of course, it always lives in my mind. And before going to space, I was a family physician working in the Arctic. So that gives me a very unique perspective on the, I think, personally obvious parallels between space medicine and medicine on Earth and why it's a good marriage for Canada. And I hope after this presentation, I will help you think that it's also an obvious sort of a parallel between the two. So I worked in Nunavik, northern Quebec, a obviously beautiful place, but also it's a bit of a, like basically working in another country for a young practicing physician. You're kind of there on your own. The family doctors there do everything basically, and it's kind of like traveling within Canada, which was really appealing for a young physician. Essentially, 100% Inuit population in this case, so had to kind of adapt to a different environment. I'm starting to use words that are familiar to the space world, also adapt to an unfamiliar environment. And I think because that was one of the starting parallels. The maybe most striking parallel was obviously the operational environment between the handful of physicians, the super nurses, the bush pilots, the first responders, the interpreters. We deliver healthcare best we can, and there's often nobody to turn to physically. Maybe you can get advice on the phone, and if that's starting to sound like what space medicine could be like, I think you are on the track to something. But this is not how I started on my way to space. It's not by being a physician. This is how I started, like everybody else, with a dream, like with a child, with an open mind and big daytime dreams. And I think this is the force of space exploration, that it has such a powerful motor engine for invention and for kind of motivation. For me personally, I remember being, I don't know, 6, 7, and when I understood what I was looking at, when I was looking at these pictures, that this is where we are. This is the world. This is where I am on this blue ball. And the photographer is on the moon. The moon is obviously very far away. You get that as a child very early. So this completely changed my perspective on things and sort of exploded it. As a child, you grow and all you know is your family, then your village, then your street, then your country, then maybe continents, and you realize you're on a planet. And eventually you realize this planet is in space, and this is reality. And there's way more space than there is Earth. Can you guys still hear and see me well?
Yes, David.
Okay, yeah, I'm getting messages that internet is unstable. That's why I'm asking. Let me know immediately. So then one thing led to the other, and thank you, Annie, for summarizing my kind of haphazard sort of career. But I was lucky enough eventually to be selected to train on a space mission. Here I am with my space brother, Oleg Kononenko, and space sister, Anne McLean. And together we trained and lived for years on the ground before living and training, lifting on a rocket, Soyuz rocket out of Kazakhstan, and making it to the International Space Station, where I spent about 7 months. I want to say a few things about the space station. I was the crew medical officer on board. I was also, like many people, all astronauts do, I was a researcher, basically, kind of a guinea pig for most of the research. The space station, in my mind, is 3 things. It is an outpost where we do research. It is a research laboratory on orbit, a unique place where we can basically study the effects of microgravity, the space environment, look at our planet as well. There is that. I think that's unambiguously an incredible asset for mankind, for humankind. But it's also almost a miracle, I would say, of international collaboration. Space station was built by a concert of nations, some of which include, Russia, United States, Japan, Germany, many other European nations, Canada. You don't have to look far back in history to see these countries at war. I think space has that incredible capacity to bring people together. It's as if we're working on a bridge above the atmosphere, a bridge above that straddles borders. And it's a realm where naturally humans want to collaborate. There's still tensions, but we want to collaborate. The third aspect, I guess, is perspective. Here's the space station, this incredible miracle of technology, of human invention, of collaboration. It's keeping alive 6 or 7 astronauts in the deadly vacuum of space. But what's behind? Behind is planet Earth. Planet Earth is keeping alive billions of us for millions of years in a giant recycling loop. And this awareness of how precious our home in the cosmos is, we owe it to space exploration. And that may well be sort of the most important, maybe, legacy of space exploration. And now we're getting on to kind of human life. Look at this little blue line there. Can you see this blue line? It is beautiful. Your mind is not prepared to see this sight, but it's also a little bit scary how thin it is. The atmosphere is like a little fog clinging on to the surface of the Earth. Look at the ocean. This is the St. Lawrence River down there. You can see Manicouagan crater if you're good at geography, but to the right, Lac Saint-Jean up there right in the middle, Montreal somewhere up to the left. At that scale, oceans are merely a coat of varnish on the planet. It is so obvious seen from space that we are all in this boat together and we must collaborate because resources are scarce. And what's even most impressive, of course, is when you turn around and look where we are, and absolutely nowhere. It's just dark, black, full of radiation, cold, meteorites, forever. Everything else you see is dead. The sun is a ball of fire. The moon is just a rock. Other planets are desperately inhospitable. Earth is our kind of our only oasis in the vacuum of space, and it's very philosophically very, very striking. And to have that sense of isolation, because you're sending people, we have had satellites for a long time in space, right? I think it's obvious for everybody that we use space all the time as a platform, as a part of our infrastructure. Each and every one of us, every 10 minutes, we use a satellite, unbeknownst to us perhaps, but space is part of everyday life of a developed nation like Canada. That's no question. It is just space not going away. We use space, we need space, we do business in space, we manage our country from space, our food, the defense, of course, the weather forecast, the positioning, just kind of monitoring of everything is done from space. What's special about human space exploration is we're sending people there in this totally forbidden place. Here I am in the cupola of the space station where we see this is where all these beautiful pictures are taken from of the Earth. The sense of isolation, the sense of dependence on the planet is also great. You are confined, isolated. At the same time, you feel this little thread that's linking you to humans on Earth, to ground control, to your family, to your species, to your roots. And it is in a way kind of your only reassurance that you know that there's other people looking out for you out there. This is great when you are orbiting the Earth. And we'll see, as Annie pointed out, as we dream of further missions, this thread will get thinner and thinner, and eventually we'll have to kind of cut the umbilical cord. During my space mission, I just have to say a few words about it. Got the chance to do all the cool things that astronauts can do, use Canadarm to capture a free-flying vehicle, put on a spacesuit to go outside and do a spacewalk. This is a very strong, powerful moment in any astronaut's career, their first spacewalk, when you are yourself a little independent satellite of the Earth in a completely 100% man-made, human-made, imagination-born system that keeps you alive, comfortable, and able to function. And this may be the epitome of technology, where we manage to take a fragile human being, put them in an impossible place, and they can be comfortable, 100% thanks to the power of creativity. A lot of research, of course, goes on board the space station. Most of the research we do is basically on the theme of healthcare or more fundamental biological sciences. The reason for that is that going to space is basically bad for you. It's bad for you at so many levels. It's fun, you float around, you bounce around, but it's actually bad for your body. Radiation, you're playing roulette with cancer. Your vascular system, cardiac system, respiratory system, neurological system, your muscles, your bones, your immune system, everything is somehow kind of taken out of their normal box by the confinement, the stress, the absence of gravity. And there's a process akin to sort of an accelerated aging that takes place. And there isn't a system in the human body that's not adversely affected by spaceflight. Some of it is reversible, some of it is not. And we spend a lot of energy trying to keep astronauts fit. We select very fit people, we screen them for disease, cross our fingers, hope for the best, but then in space still, things, people deteriorate. So what's fantastic is that the ways in which space flight affects negatively human beings, very, very similar to kind of real disease on Earth, except in space, it happens very fast in otherwise very healthy individuals. So we're like the perfect guinea pigs for medical research. There's that aspect. So for example, bone loss, osteoporosis, bone loss for astronauts, osteoporosis in the elderly, kind of similar, if not identical processes, much easier to study on astronauts. Cardiovascular problems, the immune problems, neurological problems, all of these things are studied in space. The other aspect of it is kind of how do you maintain fitness despite this bad environment? Astronauts are physiologically a little bit, I want to say, couch potatoes, because most of the time, everything is very easy, everything is very light. So our bodies are conservative in their energy, and you waste away your muscles, your bones, your tendons if you're not careful. We have to exercise really hard several hours a day to kind of maintain that. So when we come back to Earth, we're still strong. So we're learning a lot about the ill effects of sedentary lifestyles and how to counteract them, for example, with what we learn to help astronauts. We have to do a lot of medical tests on ourselves, because there's also a level of sort of fundamental science, how this affects astronauts. And for future research, we collect all these database of samples. That's very cumbersome. You have to send back those little blood vials, freeze them, send them back to Earth. Is terrible overhead, as you can imagine. And then there's the matter of self-care. So if an astronaut needs to do a procedure, have some medical procedure done, they have to do it themselves, right? We can still have, this is, for example, ultrasound, which is our main imaging technique. We rely heavily on live voice and video communication with a specialist on the ground to help us move the probe a bit left, a bit right, things like that. We have basically kind of traditional telemedicine helping us. This is possible because we're near the Earth. Eventually, it will not, as we venture further into the cosmos. So there's a lot of effort put into developing sort of tools for medical autonomy. So either diagnostics, or blood sample analysis, for example, locally, so we don't have to ship them back to Earth. Training, so that the crew medical officer on board can maintain their skills, maybe how do we, the choice of antibiotics, how do we dream of a system where we could sort of build this, make them on our own, so we don't have to decide ahead of time what to bring with us. So these are kind of chapters of where developments are happening in space. And I think these will all sound very kind of familiar and relevant to Earth. Some examples are current research on bone loss, on cardiovascular system, neurology, kind of smart clothes that will allow you to have kind of constant diagnoses, psychology also, psychology of confinement, isolation, and this technology is to do with blood tests, basically, or in situ analysis of results. All these things we dream of on Earth, right? There isn't a clinician who wouldn't love to be able to kind of monitor their patients remotely if they're fragile and sick. It doesn't have to be an astronaut in space. It can be an elderly person stuck at home. They're isolated in a way. Even a patient in the intensive care unit of a tertiary hospital, in a way they're isolated. It's difficult to move. They're just so plugged into so many tubes and wires. Of course, our military workers in different dangerous environments. So this notion of monitoring as great, we have great appetite for that on Earth. And testing. If we didn't have, we all know someone with diabetes who can quickly check their blood sugar with a pinprick. Imagine if we could do basically every possible test like that, as simply, portably. We all dream of this kind of a medicine that is very near to the patient. We don't have to bring the patient to medicine. We do the other way around. And I think in particular, the pandemic has given us kind of a great appetite for more localized healthcare system, more sort of personalized, where you don't kind of have to travel to medicine. Medicine can come to you. All right, enough about my space mission. Eventually, it's time to come back to Earth. And let me tell you one thing, coming back to Earth was rough. After months in space where I was perfectly adapted to my environment, I felt like I was born there. I was probably never been this fit in my life as the last day in my space mission. Come back to Earth, gravity just crushed me. I needed to be walked around in a chair like this. It took me weeks to sort of find my bearing, find my balance, not be kind of nauseous so easily anymore. Eventually, you readapt to gravity, of course, but keep that in mind as we dream of sending people to Mars. They're going to have a big group like this of people to take care of them upon landing. The next steps of space explorations this is where the interest lies, perhaps for you in the audience. Canada has signed up to join NASA and other international partners to build a sort of a mini space station in the moon around environments. It's going to call the Gateway, the Lunar Gateway. We're going to contribute a robotic arm like this. And this is also a good opportunity to start thinking about contributing medical services, perhaps medical experiments, medical capacity for the crew to take care of themselves. Eventually, maybe we'll settle on Mars. And again, there's going to be a great need for sort of autonomy of the crews who will live there. And then as we dream further, station is about 400 kilometers from Earth. We can fathom coming back to Earth in case of a bad problem, like a medevac. It's possible. We could certainly do good telemedicine. We can send resupplies. We can change our minds about the antibiotics of choice on board and kind of swap them. It's possible. Moon, where we're going to go back, that's 1,000 times further away than space station. Medevac is not really an option. We'll need really maybe to rely heavily on telemedicine, certainly, and think a bit harder about what we bring there. It's a bit as if we practice camping in our backyard with space station. Can always come back if the night is too cold, kind of thing. The moon, well, that's like going to the hill nearby. You better know what you're doing. You're not coming back overnight, certainly. Our real dream is Mars. Mars is a full 1,000 times further away than the moon. Mars is so far away that communication is basically 20, 30, 40 minutes back and forth between, say hi before you hear hello again, maybe half an hour delay, depending on where we are around the sun. So no more telehealth as we know it. No more resupplies, impossible medevac. We'll need full crew medical autonomy so that they can survive their way to space. We know how to send machines to Mars, right? We've sent rovers. We know how to go there and not get lost. We have never managed to send back anything from Mars, not even a pebble. And the thought of sending people to Mars and they can survive is really, we're not there yet. Station with a great life support system, every month, some major component breaks and we need to swap it. To go to Mars, we'll need something that is so reliable. And so 3 things are needed, basically recycling of resources, air, water, food, sort of a perfect life support system to go to Mars, kind of export the Earth environment to the spaceship and then to Mars for years reliably. Energy, of course, production, management, so we can come back from Mars with, we need to build a launch site basically there. And then there's medicine, because astronauts are going to be really exposed to several diseases, both physically, psychologically, huge hazards, and they're going to have to be completely self-reliant. And this is where the healthcare challenge lies. This is a great opportunity for Canada to kind of use the magic of space exploration, the magic it has of sparking innovation, of exciting the curiosity of the smartest of us. And then we scratch our heads and come up with solutions that we might not have even thought of before. And we can all benefit from that in space, on Earth. Because medicine on Earth basically has the same requirements as medicine in space. Maybe different environments subtly, but we all want the same things. With the, quote, excuse of the hardship of space exploration, this is maybe just what we need to figure out these solutions, bring them back to Earth, and then develop them on Earth first. I think that's the wise way to do it. Test them on Earth in the Arctic, for example, and test them with people who are, elderly people who are difficult to access, for example. And then when we know it works, then it will be obviously useful and be a great contribution for Canada to contribute to the International Space Program. This is all I had for you. I hope I convinced you that space medicine and medicine on Earth, similar challenges, similar requirements, similar ambitions, similar dreams, and so maybe similar solutions. If you are not from the space sector and you were wondering, well, I can confirm to you, if you are welcome to play in this arena of space technology. We need to kind of rally all the smart people in Canada who know anything, who have some ideas about healthcare, biomonitoring, diagnoses, training, for example, all these things that will be a great marriage for Canada between deep space healthcare and kind of a modernization of healthcare on Earth.
Merci beaucoup, David, pour la présentation. Thank you very much for this very interesting presentation. It's always a great pleasure to hear you talk about your experience in space and all the other amazing things that you've done and that you are still doing. So we have a couple of minutes for questions from the audience. Again, everyone, you can ask the questions in French or in English. So let's start the first question. From your experience, is there a common emergency evacuation reason, from remote sites to urban setting when you practice medicine in northern Quebec?
So when I practiced medicine in northern Quebec, maybe the most common reason for urgent evacuation was to screen for head trauma. If someone has, an accident or maybe a snowmobile accident, something like that, and then, they're kind of groggy. If you're downtown, well, you watch them in the emergency room, and if they improve, it's good. If they don't improve, deteriorate, oh, well, you go to a CT scanner and make sure they're not bleeding. In the Arctic, you got to pull that trigger early of sending them south. What we call that south, sending them to the south, because, well, it takes, there's a huge overhead. It may take 10 hours end to end, door to door. So that's maybe the most common cause. Then there's, of course, obstetrical issues, to do with deliveries. These are maybe, and then things like appendicitis, a child with an suspected appendicitis. Again, we don't have a CT scanner. We can't know for sure. So I'd say these are, you see the sort of categories, the sort of acute life-threatening emergencies is the main reason for a medical evacuation from the Arctic. And, all these things are potentially, we can reduce greatly the number of evacuations and the costs, huge cost. It's hundreds of millions of dollars for Canada every year. The cost associated with these kind of, let's just make sure type evacuations to the south. If we had the means to do these diagnoses, to nail the problem up north and know for sure, oh, we have this compact MRI for just the head, good. No bleed. It's fine. It'll be fine. We can keep him here. Things like that. Yeah.
Thank you very much. Another question, related to, again, both. Oh no, we're going in space now. A question about your time in space. So, what's the level of medical support on the space station today? What equipment and procedures are available, and what do you wish you had?
Yes. So, well, I'm sure some people in the audience will know about this if you're a little bit from the world of organization and healthcare. Everybody who manages a clinic, any clinic, be it the biggest hospital or the smallest outpost, at some point has to make very sobering decisions about what do I prepare for? What medical problems are both likely and bad enough that it's worth me preparing for? And if you are downtown Montreal, then you can prepare for everything because you have the capacity. If you're in the village in the Arctic, well, you can't just keep everything. You got to decide, you draw a line. In space, you also have to think about that. So in space, so we can deal, for example, with cardiac emergencies, just like on Earth. We could deal with fractures. We could deal with a decompression accident, because even though that's rare on Earth, in space, that's actually fairly likely, because vacuum outside, putting on a spacesuit, pressures change all the time. We have a handful of antibiotics. We kind of picked carefully which ones are maybe helping. And then minor trauma, of course, because astronauts are basically manual workers, operators. So we have to deal with all these things, little cuts and nicks and bruises and stomach ache and things like that, skin problems. So we have a basic kit that's constantly being reassessed. There is a matrix that exists that's constantly reassessed that basically lists all possible medical things. How likely are they in the astronaut population? And then how bad are they? What impact would they have on the mission or the life of the astronaut? And then we decide on a line somewhere. If something is so unlikely or so bad that it's not worth even preparing for it, then we don't. And we just hope these things don't happen. So we have a good capacity. On space station, we could still dream of a medical evacuation if it was needed. But, like if you're intubated in your spacesuit, going back on a capsule, I don't know, it wouldn't be comfortable, but it's feasible and physically. As soon as we leave the orbit environment, that will not be an option. So we have good capacity. It's been tweaked over the years with experience. luckily never had, a casualty on orbit so far.
Merci beaucoup, David. So there was one question in the chat that I'm going to answer. So David, if you don't mind, the question on it was, does CSA have a list of medical requirements? Just so you know, with our international partners, there are panels and working groups that are working on defining those requirements, both in terms of envisioning what kind of medical issues can occur, but also what are the medical technologies that will be brought on board, as well as the specific technical requirements of those technologies. So this is all in preparation, and as these will be defined and made public, they will certainly be shared with the community. But just so you know, it's work in progress as we are defining those missions to Gateway, to the lunar surface, and then on to Mars. Another question for you, David, this one will be in French. Est-ce que des équipements sont présentement utilisés dans la Station spatiale internationale pour évaluer la santé oculaire de l'équipage durant les missions? Si oui, quel type d'équipements sont utilisés? So just for the benefit of our English participants, the question is about, are there any equipment on board the International Space Station to assess
Ocular health.
The health of the eye?
Ocular health. Ocular health.
Ocular health, yes.
That's
Sorry,
right.
you see, I'm French. And if yes, what type of equipment is it?
Oui, bonjour. Ouais, merci. Alors, en fait, c'est une question extrêmement pertinente parce que c'est un des mystères, je dirais, qui reste, un des grands mystères qui reste des problèmes dont souffrent certains astronautes dans l'espace. Alors, l'hypothèse, c'est qu'à cause du shift, à cause du déplacement, de l'absence de gravité, la pression intracrânienne pourrait peut-être augmenter, hein, un peu comme si on était à l'envers, on se tient à l'envers au parc là, sur la structure, là, on sent la tête qui gonfle. Alors, il y a des raisons de croire que la pression intracrânienne pourrait augmenter et ça pousse sur les yeux et ça écrase les nerfs optiques et ça fait qu'il y a un certain pourcentage d'astronautes qui reviennent avec des pertes de champ de vision périphérique, un peu par, probablement, mais c'est toutes des hypothèses, hein, par anoxie, dans le fond, nerveuse. Fait que c'est une des choses qu'on surveille de très, très près, la vision des astronautes. D'abord, plus des tests normaux là, de qualité visuelle, mais aussi, on a développé l'utilisation de l'échographie, parce que c'est un peu la seule méthode d'imagerie diagnostique qu'on a à la disposition dans l'espace, c'est l'échographie. Donc, on fait de l'échographie oculaire et on est rendu très, très bon là-dedans. On a aussi une machine pour faire du champ proche, là, pour faire de la cartographie de la rétine très, très, très précisément avec un laser. Donc, ça, c'est un truc qu'on surveille de très proche parce que, tu sais, ça serait terrible si les astronautes se rendaient vers Mars et étaient à moitié aveugles. Ça ne marcherait pas, là. Donc, ça, c'est un peu un mystère, mais c'est un des sujets les plus d'actualité, si on veut, en médecine spatiale, c'est les effets sur la vision des astronautes. Ouais. Une affaire intéressante d'avoir la vision en passant, on est dans l'environnement, bien qu'on soit encore dans l'espace protégé par la ceinture du champ magnétique terrestre, on est quand même beaucoup plus exposé que sur Terre aux radiations. Hein? Donc, il y a des problèmes de cancer potentiellement, mais aussi on les voit, ces radiations-là. Lorsqu'on ferme les yeux à bord, de temps en temps, pouf, il y a un flash de lumière. C'est des radiations cosmiques qui frappe notre rétine.
Super intéressant. Thank you. Maybe let's go with another question. What benefits do you see in measuring biomarkers in space?
So for biomarkers, I think really what we're after is irradiation, kind of risk of cancer. To better, because right now, as far as risk of cancer in space, we're sort of ballparking it by extrapolating from things like, the medical outcomes of the survivors of the Hiroshima nuclear bombings, for example. But it's very different kind of radiation, very different region of the spectrum. So there's a lot of modeling going on, and it's just math and modeling. How reliable is it? And then we have Geiger counters on us. But again, these are optimized for the Earth. The only experience we have in terms of healthcare for our workers working, for example, in nuclear power stations. So the space environment is just we're using models to care. So I think if we had biomarkers, then we could directly see the metabolic effects of radiation and cut through the chase through all this math modeling to the biological effects. So that's certainly one place where astronauts would have to see improvement. So we have some actual measurements of potential issues that are developing. So that's one thing. And then there's just general inflammation because of the kind of the strange effects spaceflight has on the immune system. Some of it is not really well understood, not even in theory. So biomarkers would be a kind of a good handle to have if we could do that like on the spot and follow that more readily.
I see we have time for well, we'll say one last question in two part. So the first part in English is about, as we think of those missions to the moon and Mars in terms of the medical expertise required. So let's take the mission to Mars as it's a bit more complex. How do you see this medical expertise be with one crew medical officer, different type of expertise across crew members? So what's your opinion or vision about that medical expertise for a Mars mission?
So I think what's envisioned now is that there should be aboard one person with higher level of medical training. Whether they need to be an actual physician, is up to debate, but someone should be able to respond to a wide variety of problems. And everybody, should get basic first aid and basic response to, cardiac emergencies like that. Of course, then there's the quandrum. Well, what if it's the medical officer who's very sick? Then we're okay. So there's only so many layers of backup that we can prepare for. Where a lot of people argue that the medical officer on board should have surgical skills or basic surgical training and access to some surgical procedures and kits. And then again, that's in the kind of risk matrix analysis. What do we actually want to prepare for? I think what is, to reiterate what Annie said earlier, right now, the model is we take healthy people and then we test them to hell, we test everything and then send the most pristine examples to orbit and then hope for the best and ask them to be very, very careful. And then most of the knowledge and help comes from the ground, just a phone call away. And this is where the knowledge is and the immediate response. Crews are trained to respond to dire life-saving emergencies, like a fire or someone who's having an acute heart attack, things like that, or maybe a bad decompression. Okay, we'll do that. But anything that has like a 5 minutes delay, we call the ground. That role of deciding what to do in emergencies and the first steps, the kind of the first half hour, is going to have to shift to being on board. All that role or responsibility was going to have to be devolved to the crew because there is no time to get an answer. So that's a big shift for the space programs to get to a point where we can comfortably say that first sort of hour of response, that's not on board. So the crew medical officer has access to maybe like a artificial intelligence enabled sort of database or like a medical C3PO who could, give them good advice. And if they forgot, especially, I've been in space for 2 years, I don't remember, what is this rash, for example? What should I do? So kind of, and then if it's anything beyond like an hour response time, then we can basically use this space email, I guess, to get some advice. But a lot of the initial responsibility is going to have to be devolved now to the crew themselves. And that's really the problem for deep space exploration. And going back to Earth, that'd be great because there's so many nurses in remote villages and family doctors who are isolated who would love to have these tools so they can themselves respond to a wider spectrum of medical problems right away without having to consult. I think so. There's a great appetite for that on Earth. And this is maybe, again, the magic of space exploration, this like spark to make us scratch our heads a bit harder. And then lo and behold, we're always happy to have this. I like to give the example that before moon missions, computers were the size of a building. We all know that with cubes and stuff. And then NASA said, no, to the lunar vehicle, the lunar lander needs a computer this big. That's it. And so we basically invented microelectronics as we know it with the excuse of going to the moon, which to some maybe was frivolous, and just what are we spending our money there? But oh my God, we are so happy that we had that incentive. And then we realized that it's actually good to have this microelectronic. This is just one sort of high level example. But I think medicine, medical care, remote care, medical autonomy, all that we all want on Earth can be developed with the spark of space exploration, the exceptionally difficult, unforgiving environment that we're thinking of. This is just what we need, like a very, very high benchmark to help us modernize healthcare on Earth.
You know, when I hear you, David, I'm like, wow, aren't we doing the best job? You know, thinking about that future of space exploration. Thank you. We can listen to you, you know, for hours and hours. Thank you very much for taking the time. And I do hope that a lot of people that are with us today at the webinar will decide to embark on that journey and contribute to, you know, that vision for the future of human space exploration, you know, back to the moon and on to Mars. So thank you very much, David, for your participation. And we certainly look forward to hearing again from you in the future activities.
Merci Annie, merci Brad. Thank you everybody for tuning in, and scratch your heads hard. We need your brains.
Merci.
Great, thanks a lot, David, and thanks everyone for your questions. There was a ton of questions coming in through the chat and the Q&A that we weren't able to get to. Apologies on that. There are some common themes, so maybe we'll see if we can get to those a little bit in the Slack channel, either during or after the webinar here. So it's now my pleasure to introduce our next speaker, Liila Gillis. Liila is a federal government nurse leader, and she's dedicated her career to service of Indigenous populations. She's been involved in influencing healthcare delivery for over 3 decades at the local, provincial, regional, and national levels. As Deputy Chief Nursing Officer and Senior Director of Primary Care Services at Indigenous Services Canada, Liila currently leads the national policy direction for the department's remote, urgent, emergent, and primary care services across Canada. And she is passionate about helping to fulfill Canada's commitment to supporting First Nations and Inuit in achieving full ownership and control of their health services. Liila's career was built on a foundation of frontline practice in both Inuit, Nunangat, and First Nation communities. And this experience has really solidified her commitment to supporting health system change. We're really excited to have you with us today, Liila, and I will pass it over to you.
Well, thanks so much. And I'm going to project my screen, as I also have a few slides to share with the group today. So I'll just do a bit of a signal check that you can see the presentation.
Yes, we've got it. We've got it, Liila.
Okay, perfect. Thanks so much. So wow, what an incredible opportunity to contribute to innovations. I'm just so thrilled, and in fact, humbled to be here today. First, let me just situate myself a little bit. As introduced, I'm Liila, and you know, I grew up in rural Newfoundland, and you know a lot about access issues as a result of just my upbringing. But I'm also a registered nurse. And within 6 months of graduating from university, I was really fortunate to start my first role in Indigenous healthcare in a beautiful, on the beautiful Inuit lands of Nain, Labrador, Nunatsiavut. And so began my education that continues today, some 28 years later. And I really hope to share with you today a little regarding the urgent, emergent, and primary care services that we provide in isolated communities within the Indigenous Services Canada. I will sort of highlight that I am also a generalist, so I will try and endeavor to answer questions, but some of them we may need to get back to you on as we move through. And a really important part of reconciliation is to show respect and gratitude for the traditional guardians of the land upon which we work, live, and play. and also honor their courageous leaders, past, present, and future. So I am speaking to you today from my home in Ottawa, which is on the beautiful unceded Algonquin Anishinaabe territory. And the peoples of the Algonquin Nation have lived on this territory for millennia. And I want to acknowledge the traditional guardians of the lands upon which all the participants are gathered here today to start this discussion off in a good way. So I'll provide a little bit of background about our department, branch, and program, just to contextualize. Indigenous Services Canada was created in 2017 to provide and support the delivery of services to First Nations, Métis, and Inuit. And the new department welcomed First Nations and Inuit Health Branch into the suite of services from the Department of Health Canada. Our branch funds or delivers health services and works to build strong partnerships to improve the healthcare system. And now we're within a department that can connect with many of the other sectors that influence the social determinants of health. The services I'll briefly review today fall under a program authority called Clinical and Client Care. And through that program, the department funds 29 communities to deliver their own urgent, emergent, and primary care. And we directly deliver our very own urgent, emergency, and primary care in another 50 isolated communities. All of these are actually situated south of the 60th parallel and where the provincial services are limited. The services are delivered in what is commonly known as nursing stations. But these health sites are just part of a continuum of care available in the communities. They're interconnected and integrated with other health programs such as home care, mental health and addictions, Aboriginal Head Start, to name a few. On the next slide, I'll just talk a little bit more about the background, just in context. The services are delivered within these health sites on the ground, predominantly by registered nurse-led teams. They are sometimes augmented by nurse practitioners, licensed practical nurses, and paramedics on the ground, and pharmacists and physicians, sometimes on site, but often located at a distance. The team on these sites, they technically work 9 to 5, Monday to Friday, as would your doctor's office be operating, but they also are rotationally on call to support 24/7 access to urgent and emergent care. Typically, more complex medical emergencies are stabilized and then medically evacuated to a receiving center. We do not have the capability to house patients for long periods of time. We do not have the number of staff, for example, to observe patients for long periods of time. Also, for some diagnostic testing and specialty consultations, the local health professionals refer clients out for scheduled appointments as well. This slide simply depicts the various levels of services available. Local health professionals triage clients as either, first and foremost, to resuscitate to resuscitate and stabilize, as I mentioned earlier, for transport. And that really is weather permitting. Urgent care that can be effectively treated within the facility without evacuation is sort of the next category. And those cases, they wouldn't require specialized tests that are unavailable in the community to confirm diagnosis or guide the treatment decisions. These clients would have, symptomology that could determine diagnosis based on physical examination or on the testing that is available in community. And the final section or level of care is the non-urgent care. And it is on an outpatient basis. As I mentioned, we generally do not have any inpatient capability. And that level are for clients that can be more reasonably treated within the community rather than referred to a distant provincial facility or provider. So this slide just gives a depiction of where communities are generally located within the context of my overview today. And these are where clinical and client care services are funded or delivered by Indigenous Services Canada. You'll note that British Columbia does not have any identified on this slide, and that's because British Columbia have a tripartite agreement between their province, the federal government, and of course, the services are delivered under the First Nations Health Authority. So they are not directly delivered, and in fact are providing services within a new tripartite agreement. Also, on the other coast of the country, we do not provide clinical care services in the Atlantic provinces. There are similar services provided in Labrador, but they are by the provincial government. And of course, services to the territories are generally delivered by the territorial governments. For those who aren't familiar, healthcare provision in isolated communities, as it stands currently, may include long travel to access secondary and tertiary care. There is variable availability of diagnostic equipment, and nurses are supported in their practice with customized clinical practice guidelines prepared nationally and updated regularly. There are more than 350 of those guidelines, and that is in essence sort of some of the guides that are available to the nurses on the ground. And of course, there's general access to telemedicine, sometimes located in a designated room, but there are also some chronic technology challenges within the locations that limit tech support available for some of the telemedicine and or some of the other communication tools available. And like much of the healthcare system, we are challenged to retain and recruit highly skilled clinical staff that we need. I'm going to just in the next few slides go through a few proposed areas that remain challenging within our service delivery, and starting with our health human resources. Now more than ever, there's a limited supply of qualified health human resources nationally. And of course, this has been exacerbated by pandemic realities. We're about to embark on a Christmas period that we're all sort of trying our very best to maintain essential services. But in these remote locations, there is personal and professional isolation experienced by the health professionals. And it exacerbates the dynamics that can emerge within the nature of small teams. And there is limited reliability of the technology that can assist them. It's not always something that they can rely on. So some possible areas of focus are to, and that we're acting on, is to optimize the staff mix within the small teams. We are looking at that, certainly in person, but also this can be done virtually. We need to have more intuitive emergency supports for the staff on the ground, and clinical decision tools that would really help the practitioner to come up with some decision making in regards to their clients, really aids in the retention and also the recruitment of these highly skilled workforce as they would feel supported in their practice. We're also interested in innovative ways to access and maintain the well-being of the workforce, potentially through psychological testing and mental wellness supports that are readily available or virtually available for the workforce. The next slide, I'm just going to talk a little bit about recognizing the challenges of the aging infrastructure in many of our facilities, including dated design features. And I mentioned that because I've worked with some projects around robotics where, there's not, the flooring does have sort of spaces in it that doesn't allow for mobility, easily within the facility. And there are space limitations, not the kind of space limitation that they did talk about, but about sort of some of the limitations within these older infrastructures that are in communities. It's complicated further by the limitations of connectivity, and at times there's incompatible IT infrastructure. And in fact, basic reliability of phone systems sometimes lends itself to the need for innovations that don't always rely on some of these components. So, independent and autonomous support and supportive diagnostic and decision tools would be ideal. We do, more intuitive point of care diagnostic tests, real-time ways to access specialty consultation on diagnostic results, ways to virtually augment the skill sets of the local practitioner, because they can't be an expert in everything. So to successfully execute ultrasound and certain x-rays, to avoid unnecessary travel out of the community, some virtual augmentation that is accessible to these this workforce would be very, very advantageous. We're challenged to onboard and maintain the skills and abilities of the frontline workforce. As I mentioned, they have over 350 clinical practice guidelines because they can't be always up to speed and current on every potential diagnosis. We do have mandatory training, including, they have advanced cardiac life support, the international trauma life support, immunization certification, just to name a few. And if we're able to create simulations utilizing virtual reality and that were relative to the remote location where services are provided, it would certainly enhance the learning environment and aid in recruiting and retaining our great qualified staff. We have utilized, as I mentioned, some limited examples of remote presence technologies, such as robotics, dock in the box, but to date, there have been some limitations resulting from such things as reliability of connectivity. But these technologies, such as these and other augmentation tools could really be immense supports to local providers, especially for, but not limited to, emergencies. I've already referenced how diagnostic tools are limited in our current environment and that we work within communities that have limitations in the availability and reliability of broadband internet. But also, should we increase accessibility? And we are doing some additional projects around satellite access for connectivity. But we need end users, the local users, to have the skill sets that are that need to be maintained and or virtually augmented for these tools to be effective. So coming up with innovations around ways to augment and support the local practitioner is really desirable. And finally, there are information management and access issues that are complicated by jurisdictional legislation. Some of that innovation may not be able to fix, but we are talking about federal privacy laws, provincial privacy laws, et cetera. And as such, many of our staff in nursing stations still rely on paper records for their clients, paper records for some inventory management, for reporting incidents. In fact, we still have fax machines in many of our locations. And at times, even those clinical practice guidelines that I mentioned earlier, these essential tools for supporting their practice are in binders on paper on a shelf. So maintaining, updating is even more difficult without having them situated in a more accessible and easily updatable, if that's a word, format. For access to such supports as virtual care, digital medical records or electronic medical records really need to be available to providers so as to make informed and, in fact, safe clinical decisions. But we aren't there yet with many of our communities that we are providing services, and it is definitely a priority for our program area. So that was just a simple and a quick snapshot of into the reality of remote and isolated healthcare. There's so much more, I could go on and on. But we're so thrilled to be part of this exciting endeavor. And I really do see the art of the possible around what could benefit us on Earth. Could definitely be support tools and diagnostic supports for astronauts during deep space travel. So it's an exciting endeavor. We want to explore the art of the possible and improving access, quality and reliability of healthcare provided to the populations we are so proud to serve. And I want to thank the Canadian Space Agency, Impact Canada, for inviting me, for David, for such a fantastic insight into space and the connections. Merci, Miigwech, Nakumik, and thank you, everybody. It's such a pleasure to be here. So back to you guys.
Merci beaucoup. Thank you very much, Leila, for this very inspiring and insightful presentation. So if it's okay with you, we have a couple of questions coming from the audience. So let's go with the first one. So Leila, what do you think are the most urgent needs in trying to address the healthcare challenges in remote regions? Should the emphasis be on technology to support provision of care, or rather skill sets of healthcare practitioners?
That's a really good question. Both. It's one of those situations where you need to put on your oxygen mask before you help others. So I do think that a focus on supportive tools for the practitioners and the community will in fact then only prove to support the clients that they serve. So I mentioned some of those pieces around virtual reality training, virtual augmentation for those practitioners will improve the safety of the service that they're providing and enhance the care that's provided to the population they serve. So if I had to choose, I would say that some of the clinical practice augmentations and supports would be the priority, but all innovations I think will make a difference for the populations that access our health services.
Absolutely. Thank you very much. Let's keep going. If you give me just a quick minute. So you mentioned clinical practice guidelines during your presentation, and one of our participants would like to know if it's possible to get a copy of those guidelines and if they can be accessed.
Yeah, goodness, I should know this, but I believe they're actually still available on our website of Indigenous Services Canada. We are looking to change platforms of those tools into a learning management system, but I believe they still currently are situated on our website of Indigenous Services Canada. So I'll verify that if it's not the fact, but I'm pretty sure they're all on there. And in fact, I have a team within my office nationally who maintain and update them on a regular basis. We're actually going to be increasing some of those services and creating protocols that go with those practice guidelines. So you'll see that they're very common conditions, and it helps the generalist practitioner to work through differential diagnosis, et cetera, for the clients that they're seeing in the community. They are a clinical support tool.
Wonderful. Thank you very much. We have time for more questions. It's kind of a link. We talked with David about the biomarkers and the need for space. So questions about the need in the remote healthcare setting. So the question goes as follows. So what are some of the greatest needs for point of care testing? So for example, biomarkers for acute infections, infectious disease, and how long does it normally take to receive actionable results for these indications today?
Yeah, that's a really good question. I'm not sure I have the full answer for that because the availability of point of care testing is variable across the various jurisdictions. So we are situated within the provinces of Alberta, Manitoba, Ontario, and Quebec. And so, some of the, timing, et cetera, is relative to the healthcare system that the nursing station is embedded within. So they do have, for example, iStat machines within most of the nursing stations. So they can do some basic, blood work within but beyond that, there really are not a lot of testing available other than some, obviously X-ray, as I mentioned. So for most other kinds of diagnostics, the individual often needs to either leave the community or the samples need to leave the community and await. So there could be days or sometimes up, over like a week, I would say, to receive some of the results especially if the lab or the blood samples or sputum samples or others need to be shipped out to external labs. As you can imagine, it would take several days, if not more.
This is a great, link with what we need for space exploration, as we need to do, more point of care diagnosis, and we can see how it could be relevant and useful for remote communities to have results in a more timely fashion. So thank you very much. And you mentioned, the transport of the sample. We also have a question about, the transport time for patient. So we often hear that it could be, complex, difficult, and costly to do some medevac. So can you talk to us a little bit about, that transportation for patient, from their home to the location to the care facility? So if you have an idea of the typical transport time or any characteristic of that.
Yeah, I mean, again, it depends on exactly where the community is located. David spoke about some of the services in the Arctic. Clearly, their travel times would be even more. But there's kind of, I would say, the stable client that needs to be scheduled to have medical travel. So those individuals would go on regular scheduled flights out for their consultation, for their test. And of course, they have to go when the commercial airline flies out of the community. So, it definitely can be, hours of travel. And then, of course, they may need, like for a pregnant woman, as an example, to go out for a scheduled ultrasound. They're well. They need to travel out for hours away from their family. And it then is, they have a half-hour test, and then they could be 2 to 3 days before they can get back into their home community. So for a simple test, it can take, up to a week away from your home, from your children, from your family, for simple diagnostics. For emergencies, it depends on, a number of things. This is where the federal and provincial systems interface. And so, for example, in the province of Ontario, Orange would be some of the connection for our emergency client to be transported out to the nearest receiving center. And so it depends on how many other emergencies they have, if they have to respond to other communities, and the weather. There are times that our staff need to stay with a client who's critically ill, but it is not safe to land or to transport them out for the safety of everybody, including the pilots and the personnel that are transporting with. So, at the mercy of Mother Nature as well, it can be, 24 hours or more before a client can even be shipped out to a stabilizing. So, it's hours and, but is dependent, and which is another stressor on the part of the local practitioner, because some of those things are just unknown and you just never know, how long you're going to have to be with a patient, or the delays, right, with the receipt of the evacuation. Thank
you very much, Lila. We have David who raised his hand politely. Thank you, David.
Yeah, I just had to pitch in, Leila. Great answer. You nailed the conundrum of transportation. It's just not only lengthy, but it's just painful and terrible for families. And I think there's also a flip side that's worth knowing about. In most provinces, there's only 1 or 2 medevac planes, actual physical assets. And if they're going to spend, 10 hours for the full trip to go to Nunavik, pick up someone with a trauma, well, that's 10 hours where they're not going to pick up a heart attack in Gaspésie, or, a pregnancy issue in Lac Saint-Jean, or that asset has to be managed. And these trips to remote areas, they cost a lot of time. And so they strike down it. So there's a whole cascade of effects to do with these medevacs that go well beyond the problems they're trying to solve clinically, because this is part of a big network of problems. These are very rare, valuable assets that are flying constantly, and they're constantly being reprioritized. So I think it's worth bearing that in mind.
Thank you, David, and please keep your camera on. the next question, can be, for both of you, from your expertise. What is the most common case condition that require patient transport, since we're on the topic of transportation?
Yeah, no, I mean, David had referred before that there's, traumas and, I would say, I don't have that statistic in front of me, but sort of anecdotally, I think that, as you can imagine, cardiac events are probably a very common emergency. So related to, that kind of unstable cardiac, potential strokes, with the degree of chronic disease and some of the complications, these are very commonly, situations that are stabilized and transported out for the benefit of the client, for observation and for obviously emergency treatment. I don't know, David, obviously there's the traumas, the unanticipated traumas, those things come, you never know what's going to come through the door relative to, say, snowmobile accidents or others. But, certainly I think from a medical condition, I would say, cardiac emergencies, stroke would be probably up there on the top.
As often, like pediatric surgical emergencies, like suspected appendicitis. And depending on whether some remote locations have obstetrics, people can deliver there. So there's some obstetrical emergencies also, so which are basically surgical emergencies again. It tends to be surgical emergencies or patients that need intensive care units, which we don't have up north. If a patient's critically ill and you have to keep them in the village because of bad weather, that's it. You are employing 100% of your healthcare staff to take care of that one patient, perhaps.
And how do you think that this relates to deep space exploration as we see, those challenges?
Same problem, same solution. Yeah. This matrix I was referring to earlier, which I know Leila is I'm sure you're well aware of that sort of questioning. What do we get? What antibiotics? What do we keep? What tools? What this? What that? How many people? What do we prepare for? Right now in space station, we have this fantasy that maybe we can evacuate someone if it's so bad, but that would be the most costly and kind of a dicey medical evacuation ever. Soon, as we venture beyond low Earth orbit, there's just no option. So autonomy is what we need to develop, autonomy, medical autonomy. And now I think it should be clear, listening to Leila, how all of that would be welcome on Earth as well, right?
Yeah, I think, David, it's preparing the generalist, right? Like, I think it's the same for space as it is in our environment. Any eventuality could come. So, having access to reliable, tools where you can sort of just refresh and know kind of what some of those diagnostic pieces are, how to interpret, because you can't retain everything. So, I really think that's a common need between both sites, is really having an ability to have ready access to a tool that can kind of help you to bring down the diagnosis and determine what those treatments are. And I really think it's about having access for generalists that can help them to make decisions.
And not only knowledge, but also procedures. Say, okay, I have to, I don't know, inject this joint or whatever, or a nurse, okay, I have to do sutures. I mean, one of those super nurses is alone in a little village. All right, sutures on the face, it's okay. Just, can I watch a 10-minute 3D virtual reality reminder of how to do this correctly? I know I've done this before, but it was a year ago, kind of thing. That would be
Exactly.
good.
It's amazing how you are establishing those parallels between terrestrial healthcare and deep space healthcare. And I hope it is inspiring the participant. It's really, interlink. What's the word?
Intertwine. I mean, it's the same.
Yep.
Yeah,
Yep.
It's funny how it's extremely, different settings, but with very similar constraints in a way, and similar wishes. So very similar solutions, most likely. And I think it goes beyond, it's not like we're trying to make this fancy gizmo for space that we hope will be useful on Earth. That's not where we're going to do it. We're going to develop this for the Earth, and it's going to be proven to work on the Earth. We're going to use the Earth as a lab to test this stuff, and then it's going to be useful. And then if it works for these communities that we can imagine after listening to Leila. And obviously, it's a slam dunk. It will be useful in space. So that we kind of turn the tables around. Another traditional, space development that then slowly one day triggers down to Earth applications. No, we're going to turn the tables around. It's going to be developed for the needs of the Earth. But because the requirements are so similar, then it's going to be immediately useful in space.
Absolutely. A space program, focusing on delivering socioeconomic benefits to Canadians. That's amazing. And just like this challenge, as Brad mentioned at the beginning, it's focusing on more immediate impact on terrestrial healthcare and a potential pathway to space. So that benefit for remote and isolated population is really a goal with this challenge. And I'm wondering if, both of you have any advices or recommendations for innovators, in terms of how to get their new solution into remote and isolated communities, because, we know that it's not always easy to get new tools in the hand of healthcare practitioners. And any specific advice you have that could help them, to break this barrier and help you solve the challenge of remote communities?
Sorry, I lost you for a minute, Annie.
So maybe I can just reframe, shorten my question and for you, David. So I was wondering if you have any advices or recommendations for innovators that wish to have their tools, their new solution in the hand of healthcare practitioners in remote communities in order to help solve those challenges, because it's not always a direct pathway, like I have an innovation is going to be used. So any advices?
I would say, don't think of it as a space problem, because maybe that kind of sounds, exotic and difficult to frame. It's healthcare on Earth that we're trying to improve ultimately, and it's the same humans that we're just sending in this particular environment of deep space, but it's going to be humans, so it's going to be very, very similar healthcare. Maybe some things that are common on Earth are very rare in space, and vice versa. So the likelihood of things will change, but it's the same human body. So think of it in terms of healthcare on Earth and how great it would be. Imagine that nurse practitioner in a remote village, and there she goes, and someone broke their arm or whatever, or someone has maybe a heart attack. I'm not sure. I would love to kind of reassure myself with a simple blood test, or I would like to reassure myself with some super intelligent sort of cardiogram program that I could actually trust the result. Or, just think broadly. And I think anybody, I would also use, I want to speak bluntly. We've all been frustrated with the pandemic at some point, with the medical aspects of it, how it's just, I think everybody has a personal experience of how great it would be that medicine was in their hands, that they were more autonomous from a medical point of view. So if that can help you spark your imagination, you're also trying to solve the problem that you want to get tested for COVID. Well, okay, there's these kind of iffy tests, but the really good ones, you got to take an appointment and go to the hospital for. Why? I'm sure human imagination can fix those things, for example. My advice is this: don't think of it as a problem to help the astronauts. It will help the astronauts, but that might be difficult to fathom. Think of it as trying to modernize healthcare. There's so much in Canada. There's so much competency, so much innovation in artificial intelligence, medical devices, engineering, training. We're just poised to just bring it all together and to modernize healthcare and help us kind of make it more sort of closer to the patient.
Yeah, and I think I'll add to that just around for sure. That we're here for innovation. Obviously, patient safety is something that's obviously paramount. And so pilot testing and obviously not rolling things out until we're sure about the efficacy. And so this is the environment where we want to assure that obviously we've got safety protocols in place before we obviously roll out widely. But I don't think that should be a barrier to innovation. I think that we'll look for testing environments, we'll look for ways that we can assure the safety for the populations we serve, in introducing these innovations. And I just think that, I think we should just keep an open mind. It's the art of the possible, as I say.
And just one last question, to open the realm of possibilities. We've been talking about space, about remote northern population. There was a question in the chat about similarities with military settings, but also other type of population, home care or other type of challenges. So what are for you other similarities that we can still talk about?
Yeah, I mean, I can take a first stab, David. I've often said in front of senior officials, if we can have connectivity in the deserts of Kandahar, we should be able to have effective connectivity in Pikangikum, Ontario. So there are similarities. They are able to bring in certainly technologies and ways of providing safe healthcare in pretty rural and remote locations as well. So there's definitely things to learn from that sector as well. And it's just there are innovations for sure around sort of ways, and they have mobile units and ways to mobilize and move critically ill members of the military in ways that we just don't necessarily have. So there definitely are similarities. I don't know, David, you clearly would have a good sense of that too.
Yeah, I mean, I agree with you. I think if you take enough step backs, you can see the similarities that as we were mulling this over. The committee that's been working on this for over a year now is like, it's not only physically remote populations, it's what we call isolated or kind of underserved or somehow hard to reach. It's just kind of hard to reach. Anybody you can think of whom for it is tricky to go to a hospital. So, to be that an astronaut because they're in space, someone in the Arctic because they're just so far away and they want to leave the family behind, a military who's on combat, a worker in a difficult environment, an elderly person who's stuck in their home because they're not very mobile and it's a big challenge just to go to the clinic, a patient in the intensive care unit just because they're in their bed plugged in and they can't go to radiology that easily. Anybody who is difficult to reach. Anybody whom for it's tricky for them to go to medical care. We want to bring medical care to them, put it in their hands. That's where I think if you go far enough, that's the common thread that we're trying to address.
Yeah, and I think home care is an excellent example of another sector. I mean, but there are definitely pilots and things happening around home monitoring. Very much can be a good learning for this environment in regards to artificial intelligence and ability to alert when certain and to be intuitive, I guess, relative to what those home monitors are assessing. So I know that even with COVID, some COVID patients are able to be situated at home with home monitoring and successfully be sort of isolated and also monitored at the same time. So there's definitely lessons to be learned from that sector as well.
Awesome. Thank you very much. It was really a privilege to have both of you with us today to talk about the different healthcare challenge, whether on Earth or in space. I'm sure all the participants of this webinar really appreciate that time with both of you. Again, thank you very much. And we certainly look forward to collaborating with both of you for the challenge. So thank you very much.
Merci, Annie. Merci, Brad. Thank you, Leila. Thank God for nurses.
That's what I say.
So after you, Brad, for the next section of the webinar.
Great. Okay. Well, yeah, David, Leila, thank you guys so much for sharing from your experience and giving us some of that insight into the context, the challenges that we're really looking to address through this particular challenge. So hopefully participants, you were able to see some of the really clear links between the terrestrial remote Canadian context and what we're expecting to deal with in deep space. and that will help you inform your applications, your designs, and how you can modify your technologies to support some of these challenges. So I'm going to share a few details now on the Deep Space Healthcare Challenge, what we're looking for, and what it will look like through the process. If you have any questions, I know there's been a few already. Go ahead and fire them in the chat if I'm not getting to them, and we'll have some time after this section to answer those. So, in order to address these challenges that David and Liala have shared with us, we are going to need a broad range of solutions. As you can clearly see, we've got a whole host of issues that need to be addressed. And here on the screen, you can see a few different types of technologies that we can see having benefit. I know David and Liala mentioned some of these as well, particularly. But the common theme here, and the theme that you will have heard, is about providing that autonomy for the remote practitioner, whether they're in Northern Canada or whether they're in space. That's really what we need. Is we need to enable them to be able to detect issues early, so as we can prevent those evacuations that we've been talking about, or to be able to do the tests locally to avoid having to ship people out to do that somewhere else. So, like I said, this list is not exhaustive that I've got on the screen. We're looking for all technologies that could support detection and diagnosis within these communities. So, as you're preparing an application for this challenge, the key and something we really want you to focus on with any proposed solution are these three constraints need to be met in order to move forward. So once these are met, then solutions will be evaluated according to a set of evaluation criteria. But I want to highlight these briefly. And again, these will echo what you've heard from the panelists. So all solutions have to be relevant to remote communities. This is imperative. This is that terrestrial first approach that's being taken. You'll see a list of these priority areas online on the challenge website and in the applicant guide, which I believe there'll be a link to soon in the Slack channel. But it really has to be hitting one of these areas, and then we need to see some backup for that as well. The second piece here is that there has to be eventual relevance for deep space. So we need to see that it could in the future be applicable on deep space missions. Again, we have a list of conditions we're expecting to see on those missions in the future in the applicant guide that you can see. There's not necessarily going to be direct overlap between those two lists. You may be able to pick that out. But what we're wanting to see is that right now, there's relevance for remote communities, and in the future, those deep space challenges. The third piece that you'll see here is that the proposal has to show that it has the potential to be adapted to meet the technical requirements for deep space travel. So there can't be any innate pieces of the design that would prevent it from being adapted to space flight. And there's a few technical pieces there. It's not a long list that we feel would prevent it from being adapted to space. Again, that doesn't need to be a condition that's currently met, but something that could be met in the future. So if a proposal does meet these three conditions, it'll be evaluated according to a set of assessment criteria that again is outlined in the guide. You'll find that these criteria echo a lot of what you've heard from Liala and David today around autonomy, around ease of use for the practitioner, around innovation, and just that potential to have impact for practitioners in these communities. So in addition to a broad range of ideas, the challenge really does want to see a broad range of innovators involved in this. a core idea of the challenge is to bring in ideas from a variety of sources in order to introduce new solutions and to bring new perspectives into this space. So participants could be your more traditional business, SMEs, startups, that type of thing, or could be a nonprofit, could be an Indigenous organization, academic researcher or group, or even individuals and groups of individuals. It should be noted for that last piece for individuals, welcome to submit applications. In order to receive a prize, there'd be a requirement to incorporate or establish yourself as a Canadian organization. You'll also see that all applicants do need to be located in Canada, but if there's interest from international organizations, we're encouraging you to find a Canadian partner who could work with you on the challenge and make that submission with them. So the challenge will be run as a stage-gated competition, meaning that successful participants will work their way through these 3 progressive stages before the grand prize winner is chosen in 2024. So stage 1, which is where we're at right now, is open to all the organizations that we listed above. Applicants only need to submit a concept design through the application form. They don't necessarily have to have anything built. They could have something built. They could be adapting it. Again, we're quite open. And it's expected that at this stage, there'll be a fairly broad range of level of development of proposed solutions. So after the submission window closes on February 1st, the applications from stage 1 will be assessed by the jury, and 20 awards of $30,000 will be made in April of 2022. These 20 winners will advance on to stage 2 as semifinalists. And in stage 2, they'll be required to develop a proof of concept that can generate data and that can show the basic workings of the technology. In this stage, stage 2, the semifinalists will also receive support to help guide the development of the technology to meet some of the, again, unique needs that have been raised today. So this will include support from Indigenous Services Canada mentors who will provide even more insight and feedback on the remote healthcare context specific to the technology that's being developed. It'll also include a session with a regional health authority to outline the unique perspectives of these potential customers. And lastly, participants will have access to a workshop that will provide some tailored support on commercialization and common failure points for these types of technologies. So from the 20 semifinalists, 5 finalists will be chosen at the end of stage 2 to receive the award of $350,000. The finalists will move into stage 3, where they'll develop a prototype, which will be demonstrated and tested at a simulated remote healthcare facility that'll be set up and run by the CSA. The finalist that best meets the needs and goals of the challenge at this stage with their prototype will be awarded the grand prize of $500,000 in early 2024. So I referenced the jury just now, and really they're set up to help assess the proposed solutions. And we're really excited about the panel that we've put together. So the jury will be reviewing submissions and will recommend winners at each of those 3 stages to the CSA. I won't go through all of their names here, although you've already met a couple of them, obviously on our webinar today. But they do represent a very multidisciplinary group and a wide range of organizations, including the First Nations and Inuit Health Branch, the Can Health Network, MedTech, the University Health Network, the First Nations Health Authority, and many more. They're a very exceptional group. We're really privileged to have them reviewing your submissions and looking forward to working with them throughout the challenge. So all of the details that I've covered so far, and obviously lots more, are available on the challenge website and within the applicant guide. The applicant guide is where you'll get more nuance on the requirements for the challenge. So I'd encourage you to go through that. And I'll wrap up here and open up to any questions you may have on the details of the challenge.
Thank you very much, Brad. And indeed, we have some questions from the audience. So let's go with the first one. Does the funding opportunity entail infrastructure like material R&D, as well as supporting developers, researcher, grad students, salary support, and so on?
Yeah, good question. And this comes up a lot with challenges, and it's a different funding mechanism than you'll see with a traditional grant or contribution. So the prize is not actually tied to any expenses and is awarded as is, regardless of the types of expenses that have been incurred. And this is because it's funding that or awards that are made on a basis of outcomes and not of future research and development that's to be done.
Thank you very much. Second question, will we get guidance on how to establish a legal entity if we are individual participants?
There is a link on the website to that provides some guidance on incorporating as a corporation, as an individual. But if you have more questions on that, feel free to reach out directly to the challenge email and we can point you in the right direction.
Thank you. Another question, can a team apply to the challenge more than once with separate projects?
Yes. Again, we want lots of ideas. If you have more than one and more than one technology, as long as they're distinct and not just small iterations on the same technology, absolutely, we welcome multiple applications.
Yes, send as much as you want. More ideas, the better. Perfect. The next question, the funding proposed is quite limited, far from enough to have a space certified product by stage 3. So can you elaborate on the type of certification that could be expected?
Yes, there's no certification that's expected at stage 3. Again, the technologies that come out of the challenge in 2024 are not expected to go as is into space. They are expected to be able to be picked up in a terrestrial context and by providers here. And if it's something that we do see having significant value for space travel, we will there's other opportunities to go down that road with the CSA afterwards.
And if you can allow me, Brad, and I can say just a little bit more on that. So currently, I talked at the beginning about the Health Beyond initiative, and we're currently in an option analysis phase, which is we are looking at what could be Canadian contribution for deep space missions. So, technologies that could be used for the Gateway Station and then on the lunar surface and then on to Mars. And all the different investment that the CSA has been doing in the health technology area, like with the previous funding, this challenge and other opportunity that will arise in the next year, all that serve as input to identify, what are the available technologies, getting capabilities, and how is it aligned with the needs for space. So as we are collaborating with our international partners, there are some priorities that have been identified, and then we'll try to position, some opportunities for Canadian. And there will be a competitive process that will follow up, and then on that will lead to a space certification. But just at that moment, once there's a clear opportunity for space. So hope this clarify that question. There's another one. Are there any additional funding and in-kind support that could be matched with the grant?
I would hope there would be. That's a little bit outside of the context of the challenge, but definitely with other challenges, with other Impact Canada challenges, we see a lot of follow-on funding come for semifinalists and finalists. A lot of interest from VCs and other funding organizations. Because the challenge is rigorous, it's a little bit higher profile. It does really support in building the case for additional funding.
Awesome, thank you. Just let me go to Okay, can university with a linked industry team submit a grant as applicant team?
Yes. Yeah, well, again, collaborations are encouraged. It's a great way to bring together, different ideas and different experiences. So absolutely, we'd encourage that.
Yes, we do encourage collaboration. That's great. There's a question in French, Brad, so we will test your French. But we can also translate in English as this can benefit the audience. So la question va comme suit. Est-ce qu'il y aura un pointage donné à l'équipe où la note est donnée basée uniquement sur le concept? So are there any points given to like the team, the member of the team, or is it only based on the concept?
I'm going to answer in English, Annie, and you can translate for me. The assessment is based on the concept itself. So we do try to remove any ties to the organization as we're grading and as the jury's going through, to ensure that it's more about the idea and the concept than it is about the kind of experience and background of who it is that's submitting the application.
Donc, si je peux me permettre, Brad, de traduire
Ouais,
très rapidement. Donc, la note n'est pas donnée en fonction de la composition de l'équipe, mais bien évidemment au niveau du concept, et le jury ne s'attardera pas sur qui a donné l'idée, mais davantage sur l'idée en elle-même. And maybe we can highlight that the evaluation criteria are in the applicant guide that you provided with the link. Donc, je vous invite à regarder le guide qui décrit tous les critères d'évaluation sur lesquels vous serez évalué. Thank you very much. We still have time for questions. So can Canadian living abroad for grad school be part of a team to apply for this challenge?
Yes, definitely. Again, the award can only be made to a Canadian organization. So we'd encourage you to apply as an individual, and no need to incorporate or go through any legal processes before that. If you're chosen as one of the 20 semifinalists, that's what would trigger that need to incorporate or similar process.
Thank you. A quick one. Are there requirements for Health Canada certification for medical devices and technology?
Well, there are. However, within this challenge, we're expecting the development in stage 3 to be up to building a prototype, which is TRL, Technology Readiness Level 6. So we don't need to have the certifications at that stage. That would come post-challenge.
Thank you. There is a question about the evaluation criteria at each stage. So instead of talking about it, Brad, just refer them to the documents of the challenge so that they are all well described, and if that's okay.
Yeah, absolutely. And they're also listed there with weightings for each relative weightings for each criteria for each stage of the challenge. So there should be enough detail in that applicant guide to get you going.
Okay. Another question. I'm incorporated in Ontario and my company works with Canadian companies exclusively. I'm currently living in Germany. Does this eliminate me from eligibility?
No. If it's the Canadian organization that's making the application, then you qualify.
Perfect. When will applicants expect to hear back regarding the step 1 application decision?
So the stage 1 application decisions will be announced in April or early May at the very latest of 2022.
Is the challenge open to technologies that are aiming to identify new disease biomarkers that are not currently recognized as diagnostic biomarkers?
Interesting question. I don't want to, without knowing more detail, I don't want to speak directly on a specific technology and whether it would be a fit for the challenge. my sense is yes, but again, I would encourage you to go through that applicant guide, see what it is we're looking for, see how it's being evaluated, and if it meets those criteria, then absolutely I'd encourage you to apply.
Thank you. We have time for one more. Do we need to apply under a private investigator? If so, what kind of professional background should the PI have? As a student organization, does our principal investigator have to be a professor, or can it be the team lead?
So you don't need again, it's not there's not too many parallels with your traditional grant of contribution and research applications. So you will need a lead for your application. There's no requirements in terms of qualifications or who this should be. The assumption would be that it is generally the individual that's leading the team submitting the application.
Thank you. Another one, can we apply with a device that we are currently working on? So it's an interesting question about this, what's the level of maturity or the technology readiness level of the technology they want to submit the idea for?
No, it's a great question. And yes, absolutely is the answer. I would anticipate that most technologies that are currently under development would need at least a minor modification to meet the requirements of the challenge. But if they don't, I mean, hey, that's great. Absolutely send in your application based on what you have. There's no requirement for this to be built from scratch. If we have technology out there that can be adapted to meet the needs, even better.
Perfect. Thank you very much. I think we're out of time, and we answered all questions. Again, I think, Brad, that if there's any other question or if I missed one, my apologies, but they can send it to the email address, right?
Yes, absolutely. Yeah, send it to the challenge email, and we'll try to respond within 5 days.
Awesome. So, thank you very much, Brad, for answering all those questions. And I do want to thank everyone for joining our webinar. Like we mentioned, if you have any further questions, please send us an email. And if you wish to learn more about opportunities with the Health Beyond initiative and have not subscribed yet to our mailing list, please let us know by email and we'll add you to our list. Merci à tous d'avoir participé à notre webinaire aujourd'hui. Si vous avez des questions additionnelles, n'hésitez pas à nous écrire. Et si vous souhaitez en apprendre davantage sur les opportunités de l'initiative Nouveaux Horizons en santé, Health Beyond, et que vous n'êtes pas sur notre liste de distribution, s'il vous plaît, écrivez-nous, mentionnez-le et nous vous ajouterons à notre liste.
And Liala, David, thank you again for joining us, for sharing from your experience. Really enlightening and great to have your insights for potential innovators and participants in the challenge. Attendees, thank you for joining us. Hopefully this provided you some good insights, and we really look forward to seeing your applications in the coming weeks. Thanks everyone, and have a great day.
Merci tout le monde, au revoir.